Now let us begin with cases of Rh negative pregnancy. So first case is Rh negative pregnant female with ICT negative in early pregnancy. So patient ICT means indirect comb test is negative. Negative means still the immune system is not sensitized. So patient is not sensitized. The fetal maternal hemorrhage has not yet occurred. So repeat the ICT at 28 weeks. So in this case, the female is saying that still the indirect comb test is negative. So if the indirect comb test is negative, still the mother's antibody is not produced and not sensitized. So we need to repeat this. We need to repeat ICT for 28 weeks. And if it is still negative, then just give NTD. Don't give NTD directly when the patient comes and says she's ICT negative. We need to confirm it again. We need to repeat it again for 28 weeks, and still if it is negative, then give NTD. That is, you will give about 300 micrograms, or you can say 1500 international units. Okay, so 300 micrograms or 1500 international unit. The route which you give is intramuscular route, and the role is it is a prophylaxis to prevent the sensitization in present pregnancy, right? So now coming to second case. In second case, there is a pregnancy where NTD is given. So already we are given NTD, and if there is abortion, already if you are given NTD and there is abortion less than 12 weeks except threatened or complete, okay, and if greater than 12 weeks at all types of abortion. So in all these cases also we need to give NTD. Even in this pregnancy conditions like abortions less than 12 weeks we need to give, greater than 12 weeks we need to give, in ectopic pregnancy we need to give, in molar pregnancy evacuation we need to do, in chorionic villi sampling we need to do. So in all these conditions we need to give NTD. Even though they're already completed, we need to give the NTD in these cases also. Okay, so now coming to another case like amniocentesis. So even in amniocentesis we need to give NTD. In APH also we need to give, and in unexplained vaginal bleeding like fetal blood sampling, trauma, fetal death, external cephalic version. So even after the delivery we need to give like baby's blood group. If baby's blood group is Rh positive, then even though you need to give, and even DCT in baby's blood negative, that is direct comb test in the baby is negative, then also you need to give like it will be like a prophylaxis for the next pregnancy. NTD is given as prophylaxis for next pregnancy in this case. And postpartum prophylaxis. So postpartum prophylaxis is the time within 72 hours of delivery. So postpartum prophylaxis is within 72 hours. So within 72 hours of delivery we can give, or also you can wait till 28 days after pregnancy, but within 72 hours will be best. That is, here also you give 300 micrograms of dose. So the dose of NTD will depend on, actually let's just say dose will depend on, if it is less than 12 weeks it's better to give only 50 micrograms. Okay, and if it is greater than 12 weeks it's better to give greater than 12 weeks after delivery. Okay, at less than 12 weeks 50 grams, greater than 12 weeks after delivery give 300 micrograms or 1500 international units. Okay, so now let us discuss our case 3. A case 3 where pregnant female is Rh negative with ICT positive, that is indirect comb test is positive. So the immune system is stimulated now. Already the immune system is stimulated and started producing antibodies. So what is the next step? So already they are producing antibodies. So now what we need to do? The next step is to know the antibody titer. So we need to know the antibody titer. For this we need to see if it is less than 1:16 or if it is greater than 1:16. So if it is less than 1:16, what we need to do, and if it is greater than 1:16, what we need to do. So already the antibodies are produced in this female, but now what we are going to do? If the antibody titer is less than 1:6, means it is less antibodies are present, not much damage. Repeat antibody testing for every 4 weeks between 37 to 38 weeks. So in this case the woman is lucky, we can say, because here the antibodies are low. Even though they are produced, they are low. So the fetus would be safe. There will be not such acute or severe anemia in the fetus, right? But if the antibody titer is greater than 1:16, it is a concern because it is a critical titer. So in this case, there is large amount of antibody, so it is completely destroy the fetus, leading to severe fetal anemia. So the next step immediately what you need to do here is you need to do PSV, that is systolic. You should see the peak systolic velocity of middle cerebral artery Doppler. You need to do that. So after doing this Doppler, in this case, now what happened? Now in this Doppler, if you get the values which are less than 1.5 mom or greater than 1.5 mom, okay, let us see. If less than 1.5, you keep repeating the test and you do this Doppler test for every 37 to 38 weeks, okay, for every week. In the case of 37 to 38 week range, if it is greater than 1.5, do the ultrasound to check the development of Hydrox Fetalis, if there is Hydrox Fetalis or not. And in the case of significant anemia, you need to see greater than 34 of time you can deliver the fetus. If less than 34, give steroids, and you need to mature the lung of the baby, so you need to give steroids if less than 34 weeks, and do chordosynthesis. So less than 34, do chordosynthesis. So you need to see this program very carefully. Already antibody is produced. If less than 1.6, lucky, leave it. If greater than 1.6, there is critical, you need to do PSV. If this PSV is greater than 1.5, that is less than 34 weeks, you need to give steroids and you need to maintain the lung of maturity. Next, you need to do chordosynthesis. After chordosynthesis, you need to know how much exact hemoglobin is present. If hemoglobin is less than 8 or hemoglobin is less than 30 intrauterine, IUT, you need to do IUT. Try to take pregnancy till 30 to 34 weeks and deliver. Here IUT means intrauterine transfer, okay, you need to do intrauterine transfer, and next you should try to take pregnancy till 34 weeks and deliver, okay. So now for indications of pregnancy termination at 34 weeks. So if you want to terminate at 34 weeks, what we need to do? First, if there is Hydrox Fetalis, then you should terminate. If there is PSV in middle cerebral artery which is greater than or equal to 1.5, you need to terminate. Already if it is greater than 1.5, what we are doing, we are at the 34 weeks we are doing chordosynthesis, and in that chordosynthesis, if hemoglobin is less than 8, we are doing IUT. Even after IUT, if it is not possible, then of course we will terminate the pregnancy in both Hydrox Fetalis and if in middle cerebral artery Doppler greater than 1.5. So some important points are, if 300 micrograms of anti-D can neutralize 15 milliliter of fetal blood or 30 ml of feto-maternal blood, okay, so this point is important. 300 micrograms of anti-D can neutralize 15 ml of fetal blood, or you can say 30 ml of feto-maternal blood, okay. So now coming to the test to calculate the dose of anti-D. So calculate dose of anti-D by clay horse Bedke test. Already discussed about this, right? Or acid elution test, and the reagent here we use is citric acid phosphate buffer. Citric acid phosphate buffer. So if the volume of FMH is greater than 30 ml in the whole blood, the dose of anti-D should be given only 10 micrograms for every 0.5 of fetal RBC. Okay, so let me write this. If volume of FMH is greater than 30 ml whole blood, then the dose of anti-D should be 10 microgram for every 0.5 ml of fetal RBC. So this you need to see here. If volume of FMH is greater than 30 ml, anti-D should be given 10 micrograms, that is 0.5 ml of fetal RBC. Now coming to the case 4. In the case 4, you have a female with Rh negative and she is having a previous history of already hydrops in previous pregnancy. with indirect Coombs test positive. So the next step is directly measure the PSV in MCA. No need to monitor antibody titer here, because already they are saying in previously she's having Hydrox Fetalis, so no need to measure any antibody titer. Directly measure the PSV in MCA. Okay, so antigens do not need allo immunization. Let me make a diagram. So see this like information tablet here. You can see antigens which doesn't need allo immunization are Lewis antigen, I antigen, Duffy B antigen. Very important. The antigen which lead to allo immunization are Kids antigen, Kelly antigen, and Duffy A antigen. So this is important table to remember. So finally, let us discuss about Hydrox Fetalis and end this session on Doppler and Rh negative pregnancy. Okay. So what is Hydrox Fetalis? So Hydrox Fetalis is based on a cause, like either it may be immunological, okay, or it may be non-immunological. So most of it is non-immunological. Okay, in immunological you have this Rh negative type of pregnancy, and in non-immunological you have cardiovascular effects like teratology of Fallot, you have Epstein anomaly, and you have placental choreangioma, you have infection like parvovirus B19, you have sacrococcygeal teratoma, you have twin to twin transfusion syndrome, you have alpha thalassemia, you have cystic hygroma, you have Turner syndrome. So all these different syndromes are, like you can see, 90% of Hydrox Fetalis is due to this different syndromes, that is non-immunological. Okay, so how to diagnose this Hydrox Fetalis? So diagnosis is investigation of choice as USG. You need to do ultrasonography. The criteria you see is a fluid and is higher in body cavities. So whenever you see there is more fluid in body cavities, like in the scalp you'll see edema, that is subcutaneous edema, also called halo sign or Buddha sign, because it will be like this, like Buddha. Around the skull, around the scalp you'll have halo sign, so it is called Buddha or halo sign. Scalp edema, subcutaneous edema. Next you will have pericardial effusion. So around the heart you will have pericardial effusion, around the lung you will have pleural effusion, and ascites around the liver. So around all these organs you are having fluid. So in the name itself you can say Hydrox Fetalis, hydrops like water. Around all these structures you have fluid, and this Hydrox Fetalis is also seen in Hydrox Fetalis, but not a criteria, that is polyhydroamminose. So polyhydroamminose is also due to Rh isoimmunization or parvovirus B19 or placentomegaly. So polyhydroamminose is due to Rh isoimmunization, parvovirus B19 or placentomegaly. These may be the causes. Now coming to termination of pregnancy, it is better to terminate in the Hydrox Fetalis greater than 34 weeks. Greater than or equal to 34 weeks. When Hydrox Fetalis is due to Rh immunization especially, then there will be what let us see. Mainly due to Rh immunization. Then you will have PIH in mother because of placentomegaly. Alright, and next you will have mirror syndrome. So what is this mirror syndrome? Also called triple syndrome, or also called Ballantyne syndrome or pseudo toxemia. So these are the different names for the same one. So what is the triangle? What are the triple syndrome? You see there is edema in mother, there's edema in placenta, there is edema also in fetus. So edema in mother, edema in fetus, edema in placenta. So this is a triple syndrome. So this mirror syndrome can be seen especially in Hydrox Fetalis due to Rh isoimmunization, or due to parvovirus B19, or due to TORCH, or due to sacrococcygeal teratoma, or due to twin to twin transfusion syndrome, or due to placental choreangioma. So many causes. So 50% of the patients have severe preeclampsia, that is hypertension in the mothers and also proteinuria in the mothers. And there is also an imbalance between angiogenic and anti-angiogenic factors as seen in PIH, that is pregnancy induced hypertension. So management is nothing but termination of pregnancy. Okay, that is at the rate 34 weeks in the case of Hydrox Fetalis. So by this we have ended our section on this Doppler and Rh negative pregnancy. Next we'll start with thyroid diseases in pregnancy, and we'll continue with SLE in pregnancy.